We can open now the discussion of this session. And so we have actually three presenters who have lived in one country and translated their knowledge into another country. That's what you guys have in common. So that's very interesting on different subjects. And it sounds also that this session is the one with the highest rate of life-saving, I would say, because I have not seen in all the other sessions so high rates. At least that's my opinion. But we have a question here from the audience on the right side, please.
Hi, yeah, thank you all so much for your talks. I'm interested in GWAS, so I have a GWAS question for you. So it's really interesting that you found the HLA SNP and identified that. I'm just wondering, how far have you taken that? Have you looked at protein expression? Have you looked at whether it's an EQTL? Have you taken it further than just identifying it initially?
Not as far as we would like to. Yeah.
Okay.
And so I think there's some in the publication we were writing. There's the geneticists did do some QTL
Yes.
analysis. So that there's an analysis that I don't know I fully understand, but
Okay.
yeah. So they have done some work on that, but I think we feel like we're really at the beginnings, because from my understanding, it's almost like they have to do an analysis of the HLA region sort of separately.
Yes.
And so I think they're working on that. But I think part of the message from them is very strong messages. You really need more samples. And so I think they feel like this is just like scratching the surface of what we might learn. Thanks.
The second question, please, Shade.
Hi, not really a question, sort of venting a bit. Well, the overall
later.
The overall question is healthcare and access to the best healthcare a basic right, or is it a privilege? We already have in the NHS a two-tier system. There are drugs that you cannot get on the NHS. If you're child pure, you can't get. You can get if you're child pure B, if your albumin's 28 but not 29, but you've got the money, you pay for it. My concern is it's just going to get worse. But when CAR T cell therapy comes in, right, but it costs £200,000, or if someone comes up with a way to personalise an RNA vaccine for that individual to prevent recurrence, but it costs £2 million, is it ethical to allow the development of such drugs that only Bezos and Musk and Trump can afford and their mates? Or is it unethical? Or is it ethical to say, because it's fine, let only the super 0.1% of people be able to access these medicines, because in time it will become democratized? I don't know. Is healthcare a right or a privilege?
I'm taking that question. It's funny that I'm talking about this at this meeting, but I think it's a right, but look, I'm not going to deny the cost of medications are difficult, and prevention is definitely better than cure, right? So we have to invest in these programs, and it's amazing to see this. But where I think there is opportunities is in clinical trials. So, I mean, I showed you the PROVIDE study, where this is how I could access ivosidenib for my patients in a post-marketing access study where we were able to do that, right? And so clinical trials do provide an avenue, but clinical trials, our industry partners often don't want to come to certain countries, or will go to the US and go to China because they can accrue very quickly. I'm just coming to you with a solution to the problem, potentially.
But so ordinary people put themselves at risk for the trials to prove the use of drugs that they will not be able to have access to because they're too expensive.
Right, but it's still better than the patients that are now fundraising on GoFundMe pages, or who are spending their inheritance or spending their kids' inheritance going to other places to access drugs. So it's difficult. It's difficult conversations. I don't definitely have all the answers for sure.
If I may add, because it's funny, because you showed the slides of disparities in Europe, and you also showed like the Netherlands has not approved a lot of drugs because we don't think that they're not effective enough. It's not because we cannot afford them. So adding to your question or remark, is it's not only a money question, it's also an efficacy question.
So who decides that? Because that's really interesting.
That's doctors themselves. So we, as medical oncologists, we set a benchmark, and we said we at least want this as efficacy. If we don't, this study is not able to achieve that, it will not be reimbursed.
So how do you, we've had conversations this morning about trials, and I think John Primrose is gone, but like, or somebody had mentioned, oh, you're there, John, you know, whether we're doing phase 2 or phase 3 studies anymore. I was quite struck by that comment. But so when you decide efficacy, is that on phase 3?
So it's depending on the how often the disease is present. So we have off-label even registrations, and we do have for rare disease different parameters. So it depends on how often a disease is present and what the design is then made. So it's not like one fits all.
That's good.
But that's why we as doctors, because we didn't want government, neither the insurance company, to make that decision for us.
There's your solution.
I'd like to say that there are over 8 billion people in the world, and we're heading towards 9 billion, so there's never going to be equality. I mean, so prevention is better than cure, and we've heard 2 very good prevention programs here, one on liver fluke and one on Hep C. So the next thing is to find what are the other causes of cholangiocarcinoma. We know about liver fluke for 30 years. We've known about Hep C for almost as long, but we've only been able to treat it for a decade. So we now need to try and find out other causes of cholangiocarcinoma so that we can do more prevention. Because ultimately, only in the more advanced Western countries will most people be able to access these new treatments, because that is the nature of our research now. Monoclonal antibodies are ridiculously expensive. I have a disease which would be helped by antibodies to IL-6. There's no chance of me getting it in the UK, so that's the way that life is. So even in an advanced country like the UK, you can't access something which has been proven to help my condition. So if you go to Africa or you go to Asia, the chances of people accessing all these new trials that we're doing are pretty low. So we've got to go back to finding the causes. Sorry.
Is that a question for Louis, maybe? Because you were the one who's doing the whole genome sequencing study to find maybe new causes. Is that correct? Do I understand correctly?
Yes, and I think I think sometimes we think of these things as being either ors, but I think they're often both ends. It's important to do both. When sofosbuvir, which was really the first breakthrough drug for hepatitis C, was first released in the United States, it cost $90,000 for a 3-month supply. And everybody, there was this big uproar. They said it would bankrupt the healthcare system. And of course, it's much less expensive now. And once the big pharma companies had sort of recovered their investments in development, you can get 3 months supply of hepatitis C treatment in Pakistan for $30. So it's possible for us to recover the costs of investment in these drug therapies. And if we really want to get drug to people at low costs, we can do it. I think humans are incredibly resourceful. We also tend to like to hang on to resources. And I think a lot of what we see in the world is really figuring out the balance between those 2 things.
That's again hopeful, and it sounds to me like lobbying is the answer here. But there is another question.
I have a question to Dr. Gronia. Thank you so much, anyway, for advocating for us in Ireland, for patients, because it's amazing what you're doing. But I have you're focusing on, the drugs and everything, and that's amazing. But I was wondering, would it be good as well to look actually on educating staff in the hospital, especially the nursing staff. Like, I can talk from my own experience. Each time I'm there for the chemo session, like, I found most of the nurses are not aware what cholangiocarcinoma is. Each time when I'm waiting for my blood results and it's coming back, they say, oh my God, you might not getting it because, your liver function tests are so high. even though they're much better than at the beginning. And I'm trying to explain this is normal for me, so it's every single time like that. But then they're waiting, you know, for the doctor to come and just to say it for them, basically, yeah, that's fine, she can get it. And the same like with the biliary drainage, they're not aware what it is, they don't know how to deal with it. I usually have my dressing on just in case if there is any leak or anything. But once when I forgot it, like none of the nurses there knew how to deal with it. And I said, like, that's grand, I can manage, just I need some dressings. But like there was like big chaos because like they were not aware of those stuff. So just wondering, yeah, it would be good as well to focus on some education for staff in there.
Yeah, no, I think you raise a really good point, and it comes back to what I was trying to allude to earlier in terms of cholangiocarcinoma patients shouldn't be treated in 18 centres in Ireland, for example, even with systemic therapy, in my opinion. I think you do need to be in expert centres. We do need to provide education, and that's something that we can definitely do with our nurses. And there are many opportunities for nurses in education, both in the UK and in global initiatives, and we just have to kind of try and work together to do that and to help the nurses. I would like to ask a question. I know what North America is like, but in terms of a referral in your MDTs, who triages that? Because for me, this access point to MDT in Europe is critical in terms of getting patients faster access. So in the Netherlands, what happens?
Patients are referred, and because it's a regional system where we know exactly who does what, so if you have a cholangiocarcinoma, you are referred to a center, and then the patient will be seen within a week.
And is that, who triages that referral?
The nurse,
The
nurses, there are nurses here present from my center, are they? Well, they are present at this meeting, and they do the work, actually. So they are specialized nurses who are able to screen the stuff, and if they have questions, they just walk into your room and ask you. So that's all fast. And we have the electronic system for all the imaging. The only thing which we're lacking is the pathology, because it still needs post office and post sending. That's the only time-consuming stuff.
It might be, considering this is a session on international cholangiocarcinoma view, it might be quite interesting to hear some comments perhaps from some of either Stacey or Professor Valla or Helen in terms of where have you seen the real impacts happening? You know, is it patient advocacy? Is it trials? Is it the research? You know, obviously all of these things are desirable and key, but as we've just heard, we have few resources. And so where in your experience have you seen the greatest benefits if we're looking at cholangiocarcinoma globally?
Okay, well, I can only speak for the UK and to an extent for Europe. But I think the thing that's changed things for us here in the UK, not enough, not fast enough, but is having that robust data. I think until you've got the data and you can say, this is what's happening, these are the numbers of people you need to be addressing, and especially the numbers of cholangiocarcinoma cases are those who are in that important part of life where they're really important to the economy, and that's always a concern to the policymakers, because these are the taxpayers, these are the people that contribute to the economy. Sounds a bit political, but that is the case. But I think having data makes a huge difference, and you just have to keep chipping away. I mean, you just have to have the patient stories. You know, Andrea is a wonderful advocate. She never stops. She's absolutely tireless. She tells her story across... Where are you, Andrea? She will tell a fantastic story across media, everywhere, and she tells a good story, and we've got a number of patients like that. So I think it's just data, vocal patients, keep chipping away. That's it.
Stacey Lindsay, Cholangiocarcinoma Foundation in the US. I agree with Helen. I think it's data, but I really think this is a global problem. I don't think any one country is going to solve it. And I think it's very interesting. I was talking with Juan earlier. It's very interesting to me. In the U.S., the conversations are about mitigating risk, and here it's about mitigating cost. It's a very different conversation. And one thing I was thinking about, Louis, as you were presenting and you were showing that chart with all of the inflammatory, right? Everything's inflammation. And we know what the major risk factors for cancer are the same. It's obesity, it's what you eat, it's alcohol, it's exercise, it's all of those things that are cultural things, which is what the TIE group has had to do, is to educate people. And why are we not doing global education on the risk factors, every cancer community together on the risk factors for that? But also, just out of interest, since we think it's all inflammatory, and we have aspirin, and I know that your group did some work on aspirin, could you maybe just talk about that a little bit?
Yes, that's a great question, because I think the question there is, are there things that we can do that reduce risk that are cancer preventative? And the whole idea of cancer interception, I think, is very prevalent in scientists' minds these days. I think the aspirin question particularly, Dr. Khan, actually has a trial underway to try to identify whether aspirin might reduce cancer risk. We found similar data in Sweden. We looked at a study that looked at almost the entire Swedish population, and we found a significant effect of statin drugs as well, in sort of apparently reducing the risk of biliary tract cancers. So I think, yes, there are things like that we should try. Part of the challenge is that the general population risk is very low, so you have to find a group that has high risk, and that's why Dr. Khan is doing his study in PSC patients, so that he stands a chance in a relatively shorter time of being able to identify the potential effects of that risk. Or maybe he'll speak to it specifically.
It's really to address the thing about the risk factors and Prof. Bassendine's question. Even if you know the cause, human beings are really resistant to change. We know the cause of 90% of lung cancers. Billions of cigarettes are sold every day. As a hepatologist, I see young people die every month from alcohol. We know 100% what the cause of alcohol-related liver disease is. Loads of people still drink. We know what the cause of obesity is. 40% of the population are obese and are still... So even if you know what the cause... We know in Thailand that, have people stopped eating raw fish? No. So even if you know the cause, it doesn't mean that actually human beings are actually going to do anything different. So prevention with aspirin is a possibility, maybe. So we're doing this trial, which we have started recruiting. We've hit our year one targets, but it's a big ask. We need 800 to complete the trial, which is a big ask. But we'll see. We'll see how.
Okay, may I jump in a little bit here? Yeah. So actually, I do agree with Professor Khan, because, as I said, we know exactly like 70% of people in Thailand related to fluke infection, right? And then we try to screen, we try to treat them, and then we still face some of the problem after the treatment of the fluke. They don't got the reinfections, which means they don't change their behavior. So in this case, I think many aspects need to be run in parallel, right? We do screening, we do education, we do prevention. So this is the whole thing that we do. Or even the flukes in our country, the life cycle is also involved in environments. So in this case, try to setting up some of the good environment to get the fluke-free environment would be the other angle that need to be done as well.
I, by the way, didn't expect this discussion going this way, because it sounds like that we are who are we to tell people what to do? I guess people take their own responsibilities, and it's up to us to help if they want care, but we cannot expect to change everybody's behavior. This is not what I guess this society wants, unless you want a dictatorship again. Exactly. But I don't know. I'm just saying. Juan.
In fact, you just stole my comment. The thing that's impressed me most, I think, is the work that the Thais have done, really delve into the causes. And as Shahid said, we now know the causes, that with the increase in metabolic-associated liver disease, it is increasing. How do we communicate that message to have an effect? People are tired of hearing, don't smoke, don't drink, these things, and it just doesn't resonate anymore. I don't know what the panel thinks about, how do we get that message across to something that leads to change in behaviors?
I think you in UK, you did the best study on this, on the peers in the schools who have been educated to prevent smoking. And these peers had the most influence on their other pupils, on the other students. And that study showed that if you have peers and you educate those, they have the most influence on change of behavior. And why don't we learn from this lesson from smoking for other behaviors?
And I think with that, we're just exactly out of time for the session. So thank you very much for a quite existential talk. For Professor Lolomi, Dr. Roberts, and Professor O'Kane, thank you very much.